వెంకటకృష్ణ ఈ మధ్యన ఏమైనా ఇంట్రెస్టింగ్ కేసెస్ ఏమైనా అయ్యాయా కేజీహెచ్లో? Mehtaji sir, good morning.
Good morning, Shrikant.
Hello, Lens Associate. Okay, good enough. 15 or 15. Anyone start చేద్దాం. Okay, hi and everyone, good morning. So for those who don't know me, I am Dr. Shrikant Bachu, practicing anesthesiologist in critical care in ABC hospitals under Morton. So today topic, it's basically the one of the most common arrhythmia we encounter in our OTs and ICUs in the perioperative period, to be precise. But we'll be discussing our talk will be confined to the perioperative period, which may include the critical care management also if the patient is in ICU postoperatively. And it is more or less related to non-cardiac surgeries. The article is devoted to non-cardiac surgeries because in cardiac surgeries, the strategies will be somewhat different, and also the management, the risk factors, everything will be more complicated and different in cardiac surgeries when they will be directly handling the heart, as a few of the cardiac anesthesiologists present in the group will be knowing. But will be but the most of the studies, they are mainly the evidence is towards the cardiac surgeries. More or less, we extrapolate the data to the non-cardiac surgeries. So this guidelines or current evidence, what the article terms, is published in 2020 January edition of Anesthesia Analgesia. So any more recent evidence pointing to other additional therapy or changes in therapy known to anyone, we can discuss it later after the class. Okay. So coming to the introduction, perioperative atrial fibrillation, which will be termed from here on in the PPT as POAF, is common with an estimated incidence of 2 to 60% depending on the type of surgery. The reported incidence is lower in non-cardiac surgery and ranges from 4.8% following total joint replacements to 12 to 19% for esophageal, thoracic, and abdominal surgeries. So the incidence of AF is generally more in esophageal, thoracic, and abdominal surgeries for all the non-cardiac stuff we are doing. So the true incidence of perioperative atrial fibrillation in patients undergoing non-cardiac surgery is likely underestimated, because not all patients are monitored continuously in the postoperative period. Most of them will be shifting after a couple of hours, after a few hours, to the floors where monitoring is not done, and also substantially the underreporting which is taking place globally. Although historically considered as a self-limiting entity, recent evidence suggests that POF is associated with an increased overall risk of in-hospital morbidity and mortality. In addition, new onset is an independent predictor of stroke, which is the primary driver of POF mortality. So why we are worried about a mostly self-limiting entity is this particular thing, where a rare patient can land into stroke and which can lead to mortality. So although POF is more common after cardiac than non-cardiac surgery, the burden of it after non-cardiac surgery also remains considerable. So in a 2014 review, they found out that the most common acute condition predisposing to AF in hospitalized patients was non-cardiac surgery. So coming to the clinical challenges we face when we are managing a patient with AF. So what is the efficacy of current therapies targeting AF prophylaxis, and to what degree does avoiding AF triggers the atrial fibrillation triggers will reduce the incidence? So what are the effects on the short-term and long-term morbidity and mortality? How aggressively should we treat the rapid ventricular rate? And when in-home stroke prophylaxis should be initiated? What is the optimum duration of rate control therapy among patients who convert to NSR, normal sinus rhythm, before discharge? And we will be going to answer quite a few questions among this, although not all questions will have answers. So coming to pathophysiology of AF. So electrical impulses of heart normally originate. This is all will look like a more of basic stuff and just a revision of what we know about AF. So will originate at SA node and are conducted through the AV node and down to the bundle of his and Purkinje fibers to depolarize both verticals. What happens in AF, the signals are not initiated at the SA node, but instead are generated from all over the atria. So it can be a single ectopic focus or all through the atria, or multiple ectopic focus, or reentrant circuits, which will cause uncoordinated atrial activity that is intermittently and irregularly conducted through the AV node. Okay. Sorry. So at the atrial level, AF is perpetuated by the re-entry and or rapid focal ectopic firing. So this uncoordinated atrial discharge may result from an irregular atrial response to a rapidly discharging, regularly firing driver or a single localized re-entry circuit. It can be ectopic foci or a re-entry circuit. So alternatively, fibrillary activity may be caused by multiple functional re-entry circuits varying in time and space. So this is a brief pathophysiology slide, or what happens exactly in atrial fibrillation and how it causes LV dysfunction because of the loss of atrial kick, irregular rhythm, decreased coronary flow, excessively rapid ventricular rate, which will lead to LV dysfunction, and which again will cause increase in end diastolic pressure, and along with it neurohumoral changes, which will lead to atrial stretch, fibrosin, and altered calcium handling. So all these atrial stitch and remodeling and atrial fibrosis, when they occur, they will actually transform a paroxysmal or a temporary AF into a permanent atrial fibrillation. This is just the layman video may look like, but how we should explain to the patients, we can know.
Two at the top called the atria, and two at the bottom called the ventricles. Your sinus node sends out electrical impulses. Atrial fibrillation, or AF for short, is when other areas of the atria send out electrical impulses too. These irregular impulses cause the atria to twitch. When this happens, blood isn't pumped out effectively, which could cause a blood clot to form. If this clot travels to your brain, it can lead to a stroke. When your heart isn't pumping blood properly, it can lead to symptoms such as tiredness, dizziness, or feeling faint, shortness of breath, or palpitations. How AF affects you will determine the treatment you need. Some people with AF, like Harry, only have mild symptoms, or may not experience any symptoms at all. Harry noticed something might not be right when he felt his pulse was irregular and sometimes fast. Harry was at higher risk of AF because of his age and high blood pressure. Those with a heart valve problem are also at a high risk. It's important that Harry avoids further strain on his heart by getting treatment for his AF to reduce his risk of stroke or heart failure. The best course of treatment for Harry was anticoagulant medicine, called warfarin, to reduce his risk of having a stroke, followed by a cardioversion, to try and restore his normal heart rhythm. However, some people may need other treatment, such as ablation or other suitable medication. Thanks to his treatment, Harry's AF is manageable, and he can return to work and exercise when he feels ready. For more information on
Okay, thank you. Hope the audio is clear in that video. So the main purpose of keeping that video is how to explain AF to a patient in a simple language that they can understand. So then coming to the types of atrial fibrillation, the Heart Rhythm Society defines 3 types of AF: paroxysmal, which is the most common one we encounter perioperatively, so which may occur and terminate spontaneously. Persistent will not terminate without treatment, and permanent is where will not terminate even with drug or electrical therapy. So paroxysmal AF, the subtype, is most commonly seen in perioperative setting, usually results from a focal atropic firing. So one current hypothesis is that the natural history of AF, this is why the treating AF is very important, because so it actually moves from paroxysmal to persistent to permanent forms if not treated adequately, and with atrial remodeling that happens, as we have seen in the pathophysiology slide, so which will cause arrhythmia itself, and progression of the underlying heart disease also is a risk. So thus, by preventing perioperative AF, may avoid long-term development of persistent and permanent atrial fibrillation. So these are coming to the risk factors. The most important thing when we are dealing with any ailment or pathology is to identify the risk factors for the development of the specific pathology. So the risk factors are mainly divided into patient-related risk factors and surgery-related risk factors. So as you can see, hypovolemia and hypervolemia both will cause. So avoiding major fluid shifts during surgery is very important. Hypoxia can cause pulmonary arterial vasoconstriction, which will again results in increase in right ventricular pressure and then right atrial pressure, and that atrial stretch happens. So managing all these and keeping them in the right place is very important intraoperatively, and we will be discussing a few more strategies as we go across. So coming to patient-related risk factors, the single most important one, which is quoted in many of the studies, is the age. So increased risk in older patients. As we are going with more and more geriatric population and the surgeries in them, we are doing now like the Western world, we are managing 80-year-old, 90-year-old also for surgeries. And also this has to be kept in mind, the risk of developing perioperative atrial fibrillation. So coming to the impact of perioperative failure, so these patients will have higher inpatient in-hospital mortality, longer hospital strength, and increased costs. So those with pre-existing AF who develop perioperative AF will have similar outcomes compared to patients who develop de novo. Short-term post-operative morbidity and mortality are similarly worse in patients who develop perioperative atrial fibrillation. So this is an analysis conducted in 2008 called a POISE trial, perioperative ischemic evaluation trial. So this suggested that patients who develop new clinically important perioperative atrial fibrillation will have a higher risk of stroke within 30 days after surgery. Okay. So these the patients who develop new clinically important perioperative atrial fibrillation will have a higher risk of stroke within 30 days after surgery. So although the most common complications were related to infection and miscellaneous events, outcomes such as acute myocardial infarction, congestive heart failure, and acute kidney injury were also more common in patients with POAF. So these are the perioperative considerations in a nutshell in this slide. So we'll be discussing in more detail in the upcoming slides, what we will go through. So this kept as preoperative, we will discuss under the headings of preoperative what we can do, intraoperative how we'll manage, and postoperative and after the discharge too. So coming to prevention, preventing because the perioperative atrial fibrillation, is actually difficult to predict. Any of the clinical risk factors, which is where the clinical risk factors will come into play. So, are the potential target for intervention wherever possible, address patient-related factors. So, avoid perioperative triggers of sympathetic stimulation, which will actually cause tachycardia and arrhythmias. So, a 2018 meta-analysis reviewed 21 RCTs involving medications used for preventing POF after non-cardiac surgery and concluded that use of amiodarone, beta blockers, and statins was associated with a decrease in incidence of POF when compared to controls. But notably, many of the trials involved thoracic surgical patients, and thus they may not, even though they are non-cardiac, majority of them are thoracic surgical patients where they have a high risk of uh, developing atrial fibrillation. So the routine use, according to them, because the majority trials are in thoracic where they have a high incidence of AF, how much of the routine prophylactic medication can be applied to the normal population with few risk factors is still debatable. So, as we discussed, the limited data support the routine use of pharmacological agents for POF prophylaxis in cardiac surgery. So, it should remain case dependent and based on the individual risk to benefit ratio. So, coming to perioperative interventions, so we have to avoid sympathetic stimulation, avoid hyper or hypovolemia, and prompt electrolyte replacement, avoidance of hypoxia, and intraoperative hypotension may predispose to AF, and intraoperative hypotension is one big thing that can easily lead to atrial fibrillation. So then what is your choice of vasopressor? So though we use less commonly when it is a documented AF, they say vasopressin is actually associated with less atrial fibrillation in the septic surgical and non-surgical patient when compared to catecholamine-based vasopressors such as norepinephrine. So earlier use of vasopressin to treat hypertension may thus be preferred in patients with strong risk factors for developing perioperative atrial fibrillation or those who have already developed. So phenylephrine will cause reflux bradycardia, as we all know, and has been effective in suppressing focal AF, but again, the studies are actually limiting in evidence. So briefly about the ketamine and glycopyrrolate, ketamine being having a sympathetic activity even at subanesthetic doses should be avoided wherever you feel there is a strong risk factor for developing atrial fibrillation. And glycopyrrolate being an anticholinergic can cause tachycardia and dysarrhythmias, though we have almost stopped using as a routine pre-medication. It still exists in reversal agents, and care should be taken care of. In those special cases where you suspect a very high incidence of AF to happen, so Sugammadex can be a reasonable alternative for reversal, but again, its availability and even large studies are needed to establish its role in preventing AF when compared to neostigmine glycopyrrolate combination. So patient-related interventions, again, chronic beta blocker usage and obstructive sleep apnea are the two things we can discuss compared to specific patient-related when we are talking. So a few patients will be on chronic beta blocker usage. So according to the reason, they when they're using, don't stop it, and when they are not using, then don't start pre-surgery for the routine stuff. But if there is an incidence of or a strong recommendation for the usage of beta blockers, like in very strong risk factors for atrial fibrillation, they recommend to start beta blockers, and among them metoprolol is the preferred drug for preventing atrial fibrillation when we start before the surgery. And also, the evidence showed most of the studies, they pointed at restarting when we stop beta blocker before surgery for like just nil by mouth criteria and all. So again, they advise us to restart the beta blocker on day 1, not on day 0, because they found no clinical difference in the incidence of perioperative AF with day 0 starting. Maybe because of the chronic beta blocker usage, there is some plasma levels of the drug still in flowing. So they didn't find any difference between day 0 and day 1 starting. So they advise us to start on day 1. So coming to OSA, which can cause a nocturnal hypoxia, again, it's a risk factor for developing perioperative atrial fibrillation. So in the patients with OSA, it's better to go with CPAP at the night time to prevent the hypoxemic episodes and thereby the occurrence of atrial fibrillation. So coming to the management of perioperative atrial fibrillation, again, the patient comes to you on that day or the before day, maybe you found out through ECG or clinical palpation that the patient is having AF. The two main things are either is having a new onset or a pre-existing AF. You don't have an idea. So what you should do, you should cancel the surgery or postpone the surgery, what workup we can do. All these decisions actually has to be made based on the other parameters, blood pressure, heart rate, how much ventricular rate is having, and also the type of surgery. I mean, the emergent nature of surgery. You can discuss with the surgical team and also a cardiologist in consultation, and based on that you can work up for the existing time frame, if the at least the reversible causes, what all we can see, and do management before the surgery is going to start. And then continuation of anticoagulation is another consideration we'll be discussing briefly in the upcoming slides. So these are the two anticoagulants generally the patient will be kept on if the patient is having pre-existing AF or some other cardiac abnormality. So direct anticoagulants and vitamin K agonist. Vitamin K agonist and all the heparins are actually the indirect acting, they act in liver, and the directly acting anticoagulants will interfere with the coagulation cascade. So we will assess for the risk factors for bleeding if there are S, and then again we grade on the procedural bleeding risk. So based on that, we have to do either we have to interrupt the therapy or we can continue if the risk of bleeding is low. It depends on this a small flow chart to show how we make the decision, and I will share the PPT and the article, so no need to worry about this. So coming to the bridging therapy, then again, when we want to shift from oral medication to subcutaneous or IV, so the decision to bridge VKS or vitamin K antagonists and directly acting anticoagulants with unfractioned heparin or low molecular weight heparin is obviously based on patient's thrombotic risk, bleeding risk, renal function, and the risk of procedural bleeding. So timing is best is done in determined in consultation with the surgeon and also the cardiologist who is already treating the patient. Then the current expert consensus suggests that if the creatinine clearance is less than 30 ml per minute, unfractioned heparin is preferred over low molecular weight heparin. So unfractioned heparin may be discontinued 4 to 6 hours before the procedure or earlier based on the activated partial thromboplastin time. So if low molecular weight heparin is used for bridging, discontinuation is recommended at least 24 hours before the procedure. So this is another concept where they come in, where they say that bridging with a parenteral anticoagulant is again associated with some sort of complications, major cardiovascular events, and bleeding. So they suggest a simple and standardized perioperative device interruption and resumption strategy, but recently tested in patients with AF undergoing elective surgery. So this approach will actually avoid the heparin bridging and coagulation function testing and showed low rates of bleeding as well as arterial thromboembolism, and could be a viable alternative in patients taking the directly acting oral anticoagulants. So coming to intraoperative period, this is where most of the challenges lie if the patient is showing fluctuation hemodynamics and all. So the main focus should be on heart rate and blood pressure, as we all know. So the rapid ventricular rate combined with hypotension refractory to vasoconstrictor therapy will require emergent electrical cardioversion. If the patient is having unstable hemodynamics, cardioversion is the option. If the patient is not some hemodynamic stability is there, but the rate is more, then we can attempt beta blockers and calcium channel blockers. So metoprolol is superior to diltiazem, which is a calcium channel blocker, in achieving the rate control in critically ill patients with RVR, and may be a better perioperative option too. So in patients with RVR who cannot tolerate beta or calcium channel blockers, amiodarone is a reasonable alternative. So initially, actually, we should try beta blockers or calcium channel blockers, and then if it is not working, then amiodarone will be an alternative. So we all know this stuff, initial bolus followed by an infusion and all. So phenylephrine is another alternative in patients with rapid ventricular rate. Because it causes the concept of reflex bradycardia come into place when using phenylephrine. But there is no data exists to inform what should be your target rate, but a heart rate less than 110 beats per minute is usually acceptable if the perfusion is not impaired. So if possible, causes of AF and modifiable risk factors should be evaluated while stabilizing heart rate and blood pressure. Volatile agents actually do not differ from total intravenous anesthesia with respect to AF risk, but desflurane is associated with increased sympathetic stimulation and has a potential for arrhythmia. So anyhow, we are not using, in some centers they are using, but we are not using here, so not worry. So fluid status should be assessed, and hypovolemia or hypervolemia if present should be addressed. So intraoperative TE will help to rule out acute MI and guide fluid management in high-risk patients. So if possible, checking electrolytes and ABZ will prevent all the electrolyte abnormalities and metabolic stresses, which can be a potential causes for AF. So the central line was recently inserted and AF is coming, a new onset AF, check the position.
I will show you your school bus.
So coming to post-operative period, if AF persists after surgery or begins in the post-operative period, the first step would be again the preservation of blood pressure and end organ perfusion and heart rate control if RVR is present. So again, we have to identify the causes, and parallelly hemodynamic stabilization should continue. Bedside ultrasound may provide an estimate of LV function and potentially exclude acute myocardial infarction and or PE as cause. So if a patient was chronically taking a beta blocker or an NDHP calcium channel blocker like verapamil or diltiazem preoperatively, restarting the patient's home regimen and adjusting the dose based on the current clinical scenario may be appropriate. So the choice of beta blockers versus diltiazem is always a matter of debate with no clear evidence favoring one over the other. So in a sub-study of the atrial fibrillation follow-up investigation of rhythm management, AFFIRM trial, beta, which is published in 2004, beta blockers were more efficacious and achieving the heart rate than calcium channel blockers. But when we take into larger constraint, again, there are some studies which favor calcium channel blockers and some studies beta blockers are favored, but most commonly used drugs even in the clinical setting are beta blockers compared to CCBs. So again, amiodarone is a big discussion. It will be more killing more time in the presentation. So we all know the short-term complications, long-term complications, how we do. Generally, if the rate control in related to AF, they say if the rate control is not achieved by beta blockers, then amiodarone is a choice. So again, they say we can, before starting amiodarone, we can use short dose of fesmolol as it is a rapid acting selective cardioselective beta blocker. We can use esmolol in a short dose. If even to that, if a response is not there, we can start on amiodarone. And again, one more drug which is kept is digoxin, but again, its use is controversial because it has a very narrow dosage range in the therapeutic range. The toxic effects are more. But when all the drugs are failing, it can be used, or it is most commonly used in the setting of a heart failure. So, what are the options when it is refractory to medical management? So, there are two techniques. Catheter ablation can be done, and the surgical procedure is MACE. Again, in catheter ablation, AV node ablation with pacemaker placement, or curative ablation to restore the sinus rhythm. Again, there are a lot of new advances in the catheter ablation technique. There are multiple techniques going on. Maybe the cardiac anesthetist will have a better idea about all this stuff. And pulmonary vein isolation, and also there are some steerable catheters coming now instead of the fixed ones, which is taking the catheter ablation techniques to the next level. Surgical therapy in MACE procedure, where they make multiple cuts around the SA node. Again, when it is introduced in the early 1970s, from there it had gone number of editions, like our constitution MACE 1 procedure, MACE 2 procedure, MACE 3 procedure, and now a modified MACE procedure, which is a hybrid procedure where they're combining surgical technique along with the catheter ablation. So now after discharge, or when we are ready for discharge, what we do most with new onset POF convert to normal sinus rhythm before hospital discharge, and more than 95% of patients remain in normal sinus rhythm 2 months after surgery. These patients should be discharged.
It's a dark red, okay?
Sorry. So most patients with new onset POF convert to normal sinus rhythm before hospital discharge, and more than 95% of patients will remain in the normal sinus rhythm 2 months after surgery. So these patients should be discharged on rate control agents unless contraindicated, and outpatient follow-up is indicated to determine if medication regimens need to be adjusted or discontinued. So for patients who develop POF after thoracic surgery, 2014 American Thoracic Society guidelines suggest that antiarrhythmic therapy be continued for a minimum of 1 week and no longer than 6 weeks beyond the time of discharge. So these patients should be for a regular follow-up when kept on treatment for AF, either antithrombotic therapy or beta blockers, to be rechecked and assessed when to stop them. So, however, no data support a specific strategy in patients undergoing non-cardiothoracic surgery. So, the most of these treatment advisors and all are actually expert from the cardiothoracic to non-cardiac surgeries. So, in view of significant side profile of amiodarone when used over a long term, we know the lung toxicity and all. For amiodarone, it may be ideal to either convert to a beta blocker or NDHP calcium channel blocker, non-dihydropyridine, before hospital discharge, or schedule an follow-up appointment with a cardiologist to assess discontinuation as soon as possible. So coming to antithrombotic therapy after discharge, it should be considered on a case-to-case basis in patients who develop POF and patients with paroxysmal AF have a stroke risk similar to those with persistent and permanent AF. So the severity actually doesn't matter. Even a paroxysmal AF will have a stroke risk more or less similar to those with persistent or permanent. So all the current literature suggests no clear association between duration of AF and stroke. The risk of stroke for secondary AF, secondary AF such as perioperative, you trigger something during surgery and the AF occurs, which will be almost the risk of stroke will be similar to the traditional AF or due to non-surgical causes when the atrial fibrillation comes. So when appropriate surgically, anticoagulation should be restarted in patients with chronic or paroxysmal AF who are receiving anticoagulation prior surgery. Perioperative physician should consider the risk of bleeding associated with surgical procedure, the general bleeding risk, and the patient's thromboembolic risk. So it's a fine balance as we do for most of the things in anesthesia and critical care. So we have to assess the bleeding risk and also the thrombus formation risk, and based on that, on an individual basis, we can actually suggest the further course of treatment for the patients. So generally, when we are going on a fine edge, the risk scores will actually help. So I have kept a few risk scores for bleeding risk scores which are internationally accepted. So chart as square score, and these two has blood, and there is a modification of that chart score, adding few more parameters. So all these parameters are taken into consideration when we are assessing the bleeding risk. So Hasbled score of more than 3 indicates high bleeding risk, and higher scores correlated with even more higher risk of bleeding. So oral anticoagulation is indicated in men with CHAD score, VAS scores of more than 1, and women with scores more than 2. So all of these tools have been validated in general medical patients. Again, their validation is not adequate or not based on strong research evidence in post-surgical patients. So even though the pathophysiology of thrombus development caused by AF is similar in both settings, surgical patients are at a higher risk of bleeding. So obviously we have to keep a lower threshold for perioperative patients. So coming to take-home points, so AF is the most common perioperative arrhythmias with potentially increasing incidence as progressively older patients present for surgery. POF can develop both de novo and in patients with a history of AF. Avoiding perioperative triggers and optimizing patient-related factors are currently the mainstay of prevention, and further research is needed to better identify the impact of such strategies. So intraoperative prevention will follow the same general goals in minimizing potential triggers such as hypertension, sympathetic stimulation, hypoxia, hypercarbia, and metabolic abnormalities. The potential impact of intraoperative anesthetic agents such as ketamine, glycopyrrolate, and desflurane also needs further evaluation and more strong evidence. So because of the natural history of AF progressive from paroxysmal to persistent to permanent subtypes, preventing a paroxysmal AF in the perioperative period will actually avoid eventual progression to more dangerous forms and have considerable long-term health consequences. Although previously considered a benign and self-limiting entity, POF worsens postoperative outcomes, can be a harbinger of stroke and severe disability, and increases the risk of postoperative morbidity and mortality. So postoperative continuation of rate control therapy initiated during the perioperative period is currently recommended even for paroxysmal AF, and further study is needed to validate that approach. Because of the heightened risk of stroke, prophylaxis should be discussed between anesthesiologist, intensivist, surgeon, and cardiologist. It's basically a multidisciplinary approach with a focus on the risk-benefit profile of such interventions. Thank you so much for the patient hearing. Inputs from people more dealing with cardiac cases and all.
Thank you, Srikant. Practically, how many cases you deal with the atrial fibrillation? How to manage?
Non-cardiac cases. Well, actually, we have recently seen a tough, when we discussed in last critical care class, that post-craniotomy, we had a fight or antibiotics, but parallelly when the fight or antibiotics is going on, actually the patient is having a recurrent atrial fibrillation. She's a patient of severe mitral stenosis, madam. So the patient is having a recurrent AFs like every two days, like that. We have seen again atrial fibrillation to occur with rapid ventricular rate and all. So at no point she didn't need cardioversion, but she was kept on a because of the failure component, she was kept on digoxin tablet, and we have given initially metoprolol tablet, and this one, when there is no response and the AF is recurring, we have kept amiodarone infusion for two times. With amiodarone, it's settled down. Didn't need further intervention, but this recently we have seen that I think I thought for some time that it's going to be refractory AF, but eventually it settled down. We have kept IV infusion, then followed it with Cardron oral medication, 200 mg TID, then 200 mg BD, then made it 100 mg and stopped before moving the patient out of ICU. It eventually settled down, but I think generally, like if AF comes more of like our hand goes first to amiodarone, so I learned that beta blockers should be tried. Metoprolol also, I think IV can be given. So we'll try from here on. I don't know regarding cardiac, but non-cardiac, this is we quite fairly encounter in the perioperative period.
Okay, in your mitral stenosis, no. So any thrombus is there? Left atrial appendage.
LA clot is there, madam, for that patient. That's a bomb.
So if LA clot is there, it is contraindicated cardioversion.
Oh, okay, okay.
So next, any AF patient, is it rate control is important or rhythm control is important?
To me, there is a RVR rate control definitely important. Man. Initially, even in the treatment part also, they're suggested to do rate control.
Yeah, practically rate control first our goal, later on rhythm control. Next, whenever any thrombus is there, it is contraindicated cardioversion. In medical management, if any thrombus is there, first go for medical management, warfarin, anticoagulants, and the later we can come to the OP, I mean ICU, and do the cardioversion. Like this in the textbook, like this is given. And in cardiac surgery, every day we are seeing the atrial fibrillation. That is a CABG or mitral valve case, anything. Commonly, we saw the atrial fibrillation. So that is a chronic AF. That means if you are give the drugs and after surgery also, sometimes it disappears, but 70% it continues AF. You have to concentrate rate control only. If rhythm reverted also, it will come later and sometimes immediately. And more concentrate about, you told about hypokalemia, hypomagnesemia, and metabolic acidosis. When patient is metabolic acidosis, hyperglycemia, hypokalemia, it patient go to AF. And CABG patients also is going for AF. That's why we are preoperatively we are starting beta blocker or prolometexel, metexel or anything. If already patient on beta blocker, you can continue the beta blocker and take for surgery. That is we are following.
Thank you, madam. Any more points to add from your practical experience of dealing with a tough atrial fibrillation case?
Good morning, Srikanth.
Sir.
Which is more dangerous, paroxysmal AF or persistent AF?
Sir, obviously it's like a chain, sir, but persistent AF is all obviously tough to treat, definitely, as we have seen in a number of cases.
ఒక్కసారి ఆ ఫ్లో చార్ట్ ఉంది కదా శ్రీకాంత్, ఏ ఫ్లో చార్ట్
సరే సార్
ఏఎఫ్ ఐడెంటిఫికేషన్ ఫ్లో చార్ట్ ఒకటి ఉంది కదా ఏఎఫ్ ది,
అది సరిగా కనిపించట్లేదు సార్, అందుకే పీపీటీ మళ్ళీ చూపుతా అన్నారు.
Srikanth, the paroxysmal is more dangerous because of the risk of thrombus.
Okay.
చిన్న డిస్కషన్. ఇప్పుడు ఏఎఫ్ లో నార్మల్ గా మీరు ఎంత జోల్స్ ఇస్తారు షాక్ హైపర్ టెన్షన్ అంటే?
$50 joules or 100.
సింక్రనైజ్డ్ కార్డియోవర్షన్ సార్.
అదే సింక్రనైజ్డ్ కార్డియోవర్షన్ ఎన్ని జోల్స్ ఇస్తారు?
50 సార్, విత్ సెడేషన్.
బట్ నార్మల్ గా నాకు తెలిసింది ఏంటంటే 3 పాయింట్లు: సెడేషన్, సింక్రనైజేషన్ అండ్ ఈసీజీ లీడ్స్ కనెక్ట్ చేయాలి. కానీ ఏంటంటే మొన్న నేను ఒక పేషెంట్ కి ఇక్కడ కార్డియాలజీ ఐసీలో చూస్తుంటే కార్డియాలజిస్ట్ అందరూ కూడాను ఇమ్మీడియట్ గా 200 జోల్స్ ఇస్తున్నారు కార్డియోవర్షన్. ఎందుకని అడిగితే వెంట్రికులర్ ఈజీగా కరెక్ట్ కన్వర్ట్ అవుద్ది కానీ ఏట్రియల్ కన్వర్ట్ అవ్వదు సరిగా ఈజీగా. అందుకోసం మళ్ళీ 2-3 సార్లు ఇవ్వడం ఎందుకని ఒకేసారి ఇచ్చేస్తాం అని చెప్పి అంటున్నారు. ఇఫ్ ద పేషెంట్ ఈజ్ ఇన్ హైపోటెన్షన్. సో అదేమన్నా రీజన్ ఉందా లేదా తెలుసుకుందాం అని అడిగాను, నాకు తెలియక.
సార్ ఏంటి ఇస్తారు సార్ ఫస్ట్ వాళ్ళు?
No, they give more joules, not less joules. They give directly 150 to 200.
అది మేబీ డిసి వర్షన్ అయిపోయింది కదా సార్.
సింక్రనైజ్ చేసి, వితౌట్ సింక్రనైజేషన్ కాదు, సింక్రనైజ్ తోనే.
అంటే ఫుల్లీ సెడేటెడ్.
Fully sedated. They are telling that instead of giving 2-3 times, better to give once. 150 ఇచ్చేసేయండి స్టార్టింగ్ లో అని చెప్పేసి అంటున్నాడు. అంటే కార్డియాలజిస్ట్ డాక్టర్ రంగనాయకులు అడిగాను. అంటే యాక్చువల్లీ వేరే వాళ్ళు ఇచ్చారు అలాగా, ఎందుకు ఇచ్చారని నేను అడిగాను. కొంచెం ఎందుకు అలా చేస్తాను మీరంటే, లేదు సార్, వెంట్రికులర్ ఈజ్ ఈజీ టు హ్యావ్ ఏ కరెక్టెడ్ దిస్ వన్ ఆర్ షాక్ అయిపోద్ది. సూప్రా వెంట్రికులరే కొంచెం కష్టం, అందుకోసమని కొంచెం హై డోస్ లో ఇస్తాము, అది బెటర్ అని చెప్పేసి అన్నారు. మరి రీజన్ ఉందో లేదో నాకు తెలియదు.
సార్ కేర్లో కార్డియాలజిస్టులు కూడా 100 ఇస్తున్నారు సార్, నాట్ 50. 100-150 అలాగే ఇస్తున్నారు. మో ఛాన్స్ ఆఫ్ రివర్టింగ్ క్విక్లీ ఒకసారి ఇస్తే ఇన్స్టెడ్ ఆఫ్ కీప్ రిపీటింగ్ అని చెప్పారు. ఎందుకు అలాగే ఇస్తున్నారంటే
మాకు అలాగే చెప్పారు. కానీ ఏంటంటే స్టార్టింగ్ లో అదే రీజన్ అంటే సుప్రా వెంట్రికులర్ ఇస్ మోర్ డిఫికల్ట్ టు గెట్ ఇట్ రిథమ్ దాన్ అంటున్నారు. మరి ఐ థింక్ వరలక్ష్మి క్లాస్ లో ఉన్నట్టుంది. అదే ఏమన్నా ఫస్ట్ రీసెంట్ ఏమైనా ఉందమ్మా?
I think madam left, sir. Yes,
అంటే క్రానిక్ ఏఎఫ్ నాట్ రెస్పాండింగ్ టు ట్రీట్మెంట్ అనుకున్న వాళ్ళకి డైరెక్ట్ గా వెళ్ళిపోతున్నారేమో సార్ 100-150.
అందుకోసమే అడుగుతున్నాను శ్రీకాంత్. నాకు తెలియక నేను డిస్కషన్ లో అవుతుందని చెప్పి అలా చెప్పారు వాళ్ళు, అది చెప్పారని చెప్పి అడుగుతున్నాను. ఇది ఎనీథింగ్ రీజన్ అంటే సుప్రా వెంట్రికులర్ ఇస్ మోర్ డిఫికల్ట్ టు గెట్ కరెక్టెడ్ దాన్ వెంట్రికులర్ అడిగారు. ఆ రీజన్ ఒకటి, ఆ పాయింట్ ఒకటి అర్థం కాలేదు.
ఏఫ్ అయితే ఒకసారి చేశాను సార్ మా ఎస్ఏలో, దెన్ వీ హావ్ గివెన్ బైఫేరిక్ 50 ఓన్లీ విత్ ప్రొపఫాల్. బట్ హై కరెంట్ ఐ విల్ సే చెక్.
ఫైనల్ గా ఇట్ ఈస్ గోయింగ్ టు స్టాప్ ద హార్ట్ కదా.
అదే కదా సార్, అదే అయిపోతుంది.
అంటే నా ప్రాబ్లం ఏంటంటే ఎక్కువ షాక్, నా థాట్ ప్రాసెస్ అంటే ఎక్కువ జోల్స్ లో ఇస్తే అండ్ ఇట్ మే నాట్ కమ్ బ్యాక్ టు నార్మల్ సైలెన్స్ అని భయం. అంటే ఎస్ఏ నోడ్ కూడా అయిపోద్దేమో అని, అది నా థాట్ ప్రాసెస్. బట్ ఇప్పుడు ఓటీలో రెగ్యులర్ గా ఓటీలో కూడా గమనించాను, స్టార్టింగ్ లో ఓన్లీ 4% ఆఫ్ ద జోల్స్ అంటే టోటల్ 200 జోల్స్ వస్తే 4% వెళ్తుంది కదా, అక్కడ 8 జోల్స్ వెళ్తుంది అనుకున్నాను. ఇంట్రా మరి అనురాధ రెగ్యులర్ గా ఇస్తుంటది కదా షాక్, అది స్పూన్స్ తో, అది నార్మల్ గా 8 to 10 జోల్స్ వేయాలి, కానీ అక్కడ మనం 20-30 అలా ఇస్తాం. ఎన్ని ఇస్తాం అనురాధ రెగ్యులర్ గా? 30-40 కూడా ఇస్తాం కదా.
అంటే ఫస్ట్ 10 జోల్స్ స్టార్ట్ చేస్తాం సార్, 10-15 వరకు వెళ్తాను. నెక్స్ట్ బిగ్ హార్ట్, డైలేటెడ్ హార్ట్ అని డౌట్ అనిపిస్తే నేను డైరెక్ట్ గా 15 జోల్స్ పెట్టేస్తాను. 15 జోల్స్ అంటే మాక్సిమం 15 కి అయిపోతుంది. వెరీ రేర్ గా 50 జోల్స్ వరకు వెళ్ళామంతే.
అరవింద్ ని అడుగుతాను సార్, ఇప్పుడు మనోడు హై అండ్ కార్డియాక్ సెంటర్ లో ఉన్నాడు కదా.
ఎక్కడ ఉన్నాడు ఇప్పుడు?
అది ఢిల్లీ ఫోర్టిస్ లో సార్, కార్డియాక్ అనస్థీషియా జాయిన్ అయ్యాడు, డిఎం కార్డియాక్ అనస్థీషియా.
అవును తెలుసు, బట్ ఎక్కడ?
వెరీ ఫేమస్ హార్ట్ ట్రాన్స్ప్లాంట్, మంచి పేపర్ లో వచ్చింది కదా, ఆ ఓటీలో ఉన్నాడు. హార్ట్ ట్రాన్స్ప్లాంట్ అయినప్పుడు అంటే పక్కకు తోస్తారు అనుకోండి, మనం జూనియర్ కాబట్టి, బట్ హీ వాస్ దేర్ అట్ ద హార్ట్ ట్రాన్స్ప్లాంట్ అండ్ ఫెల్ట్ వెరీ ఎక్సైటెడ్. మంచి వాల్యూమ్ అవుతుందండి సార్ అక్కడ. జస్ట్ ఆస్కింగ్.
అంటే నేను మామూలుగా ప్రాక్టికల్ గా ఏం చేస్తున్నాడు, ఎందుకంటే థియరీగా మనకు తెలుసు, మనం డిస్కస్ చేస్తున్నాం, కానీ ప్రాక్టికల్ గా చూసేప్పటికి ఎక్కువ అవుతుంది. దాని రీజన్ మనకు అక్కడ రాయట్లేదు, అందుకోసమని.
డెస్ఫ్లోరైన్ వాడుతున్నారు సార్ ఎక్కడైనా? డెస్ఫ్లోరైన్ ఎవరైనా ఏ సెంటర్ లో మనకి వైజాగ్ లో?
అంటే కేర్ లో ఒక డెస్ఫ్లూరెన్ ఉండేది, ఒక తర్వాత కొంచెం కనెక్షన్ ప్రాబ్లం వచ్చి తీసేసాం.
మేము నెల్లూరులో వాడాము శ్రీకాంత్, గవర్నమెంట్ హాస్పిటల్ నెల్లూరులో డెస్ఫ్లోరెన్ సప్లై ఉండేది.
నెల్లూరులో సార్, ఫస్ట్ బెంగళూరు అనుకొని తర్వాత నెల్లూరు అనుకొని స్టార్ట్ అయినాము. సూపర్ అసలు. ఓకే. Actually, అంటే this literature says desflurane carries higher risk of AF than other volatile agents. Experience ఉందని అడిగాను సార్ అంతే.
We use it desflurane, but never seen AF.
ఓకే సార్. కేర్లో ఓకే.
దానికి ఏదో రూల్ ఆఫ్ 7 ఉంటుంది, డైల్ మీద 7 పెట్టాలి, 7 మ్యాక్ 7 minutes తర్వాత ఇండక్షన్ వస్తుంది.
ఓకే ఓకే.
ఈ లోపల AF వస్తుందా?
కాన్ఫిడెంట్ గా చెప్పాడు కదా సార్, రాలేదని.
శ్రీకాంత్, ఇది ఇప్పుడు రీసెంట్ గా ఇవాపరేట్ అవి వాడుతున్నారు కదా రేట్ కంట్రోల్ కి.
అవును సార్, అవునవును అవును అవును.
అది అంటే ఈజ్ ఇట్ బెటర్ దాన్ బీటా బ్లాకర్?
Even I had to accept I need to study more when comparing those two drugs, sir. But based on physician and cardiology suggestions, we have used quite a good times in our ICU, sir. Like 5 or 6 times వాడాము. It's like ఈవెన్ కొన్నిసార్లు సర్స్ అవి వచ్చి అంత అన్కంట్రోల్డ్ రేట్ కి వెళ్ళినప్పుడు, అండ్ ఆల్సో వెన్ ఇట్ ఈస్ అసోసియేటెడ్ విత్ రిథమ్ డిస్టర్బెన్స్, ఇవాబ్రేడిన్ వర్క్డ్ వెన్ ఇట్ ఈస్ రిఫ్రాక్టరీ సార్. మిగిలినవి పంచ్ అయినప్పుడు ఇవాబ్రేడిన్ వర్క్డ్ యాక్చువల్లీ టాబ్లెట్. ఇప్పుడు అందుకని ఐసీలో ఒక 10 టాబ్లెట్లు తెప్పించి అక్కడే పైన మా చిన్న హోల్డర్ ఉంటది అక్కడ పెట్టాం అనమాట. సో
కాదు, ఈజ్ ఇట్ వర్క్స్ బెటర్ వెన్ ఇట్ ఈస్ అసోసియేటెడ్ విత్ పల్మనరీ హైపర్టెన్షన్?
No, some of these patients had mild to moderate PAH, sir. But that's what I'm saying. Actually, I need to study more to establish my clinical.
Anuradha madam may throw much light on this.
యూస్ చేస్తున్నాం కానీ, అంటే వెన్ ఎవర్ హీమోడైనమికలీ స్టేబుల్ విత్ ద హార్ట్ రేట్ ఈజ్ హై, దట్ టైమ్ ఇవాపరేట్ ఈజ్ యూజింగ్ సార్.
పల్మనరీ హైపర్టెన్షన్ కి దానికి సంబంధం లేదా మేడం?
అది అంత ఐడియా లేదు సార్ నాకు.
Sir, ICU లో not for AF, sir, not for AF, but very high rates, sinus tachy, more than 140 persistently, even after ruling out all the causes and disturbances. Ala unnappudu we are trying to, sir, we see 150, 160 rates, which itself may compromise hemodynamics. Alantappudu we are trying, but not for treating AF. But not for this cause.
ఆ కాజ్ కే ఇచ్చాను మెకానిజం, అది మనకు ఐడియా.
మేడం సార్,
ఒకప్పుడు మనం అరిథ్మియాకు ఎప్పుడు లిగ్నికైన్ ఎక్కువ వాడేవాళ్ళం.
అవును సార్.
తర్వాత కార్ట్రాన్ వచ్చిన ప్రధానికి కార్ట్రాన్ వాడుతున్నాం, ఇంక్లూడింగ్ ఏసీఎస్ ప్రోటోకాల్లో.
అవును సార్.
ఇప్పుడు మెటాప్రోలాలు, బీటా బ్లాకర్స్ మనం రెగ్యులర్ గా టైం టెస్టెడ్. ఇప్పుడు కొత్తగా ఇవ్వబడిన వచ్చింది, ఆల్మోస్ట్ చాలా ఎక్కువ మందికి వాడుతున్నాం. సో మేబీ ఇట్ ఇస్ మోర్ సేఫర్ అండ్ డోసెస్ కూడా చాలా తక్కువ ఇవ్వచ్చు, చాలా ఎక్కువ ఇవ్వచ్చు. దానికి వచ్చిన ప్రాబ్లమ్స్ అంటే సడన్ గా అదర్ అరిథ్మియాస్ తక్కువేమో అనుకుంటున్నాను. మేబీ ఇట్స్ యూజింగ్ నవ్ డేస్ మోర్ యూజింగ్, పీపుల్ ఆర్ యూజింగ్ మోర్.
అవును సార్, ఇక్కడ ఆర్కేలో కూడా బాగా వాడుతున్నారు ఫ్రీక్వెంట్ గా.
So the only thing is you cannot use ivabratin for longer time like beta blockers.
Why sir?
It is not advised theoretically or in studies also. They used it for supraventricular tachycardia, which is not responding to beta blockers. Once the rate control has been achieved with ivabratin, they are switching again to beta blockers to control the rhythm.
శేఖర్, ఇది శేఖర్, ఈ రేట్ కంట్రోల్ అంటే బికాస్ వీఆర్ యూజింగ్ సో కామన్లీ ఇన్ ద పెరియాపరేటివ్ అండ్ ఇన్ ఐసియూస్, I think it would be better to take a class on rate control and rhythm control drugs, like or 2 classes DNB students. అంటే నిన్ను అడ్రస్ చేయడానికి రీజన్ అదే.
Yeah. Actually, I'm planning regarding antiarrhythmic new classification and everything. I'm actually studying it, and I will present, or one of the students will present antiarrhythmic in the near future.
Because DNBs కి కూడా అది లాంగ్ క్వశ్చన్ కదా.
Yes.
లో అది అంటే ఆబ్వియస్లీ DNB లో కూడా మంచి క్వశ్చన్ కదా. We can plan a detailed discussion.
అంటే కేర్ సెషన్ ఉంది కదా, కేర్ సెషన్ ఫస్ట్ స్టూడెంట్ లేటర్ కన్సల్టెంట్ ఉంది కదా. సో స్టూడెంట్ ఒక పార్ట్ 1 ప్రెజెంట్ చేస్తారు, నెక్స్ట్ కన్సల్టెంట్ పార్ట్ 2.
ఈ ఐడియా బాగుంది మేడం. నైస్.
సరిపోతుంది.
Srikanth, what is the drug of choice for multifocal variable atrial tachycardia?
ప్రాసెస్ చేయడానికి కొంచెం టైం పడుతుంది. డ్రగ్ ఆఫ్ చాయిస్ ఐ డోంట్ హ్యావ్ అంటే స్పెసిఫిక్ గా దానికి అంటే తెలియదు సార్.
సార్ ఒకటి అంటే బెస్ట్ ఆన్సర్ ఏంటంటే హీమోడైనమికల్ అన్స్టేబుల్ గో ఫర్ షాక్, హీమోడైనమికల్ స్టేబుల్ కార్డ్రాన్.
మెగ్నీషియం మేడం.
అది
మీరు అవుట్ ఆఫ్ సిలబస్ చెప్తున్నారు.
అంటే హీమోడైనమికల్ స్టేబుల్ అయితే మెగ్నీషియం బెటర్ అన్నాడు. అంటే ఇది కామన్ ఇన్ COPD కాంప్లికేషన్.
మెగ్నీషియం ఎస్పెషల్లీ ఫర్ టార్సైడీ పాయింట్స్. యాక్చువల్ గా హైపోకెలీమియా కంపల్సరీ వీఆర్ కరెక్టింగ్ ది పొటాషియం కంటిన్యూస్లీ బట్ నాట్ రెస్పాండింగ్ ఆల్సో. యాడ్ మెగ్నీషియం 1 gram.
2 grams కదా మేడం?
1 gram సరిపోతుంది మేడం. నేను 2 grams యాడ్ చేస్తాను.
కాదు అంటే యాంపుల్
2 grams only. In my as per my knowledge, it's 2 grams only magnesium.
Okay then.
And one more thing, magnesium is more beneficial in ventricular tachycardia rather than atrial supraventricular. It stabilizes the membrane better. Ventricle. It stabilizes the ventricle more than the atria, sir. As far as I know, it's more for ventricular tachycardia, and as the madam said, torsades point and everything. Where the arrhythmia is more of ventricular rather than atrial.
That is more related to magnesium. Aithe you can go for 2 grams.
Shekhar.
I'm saying, sir, magnesium is more used in ventricular arrhythmias rather than atrial arrhythmias.
No, sir. It is given in
in
Oxford Handbook of Clinical Medicine that it is the drug of choice for supraventricular multifocal atrial tachycardia.
Okay. I'll just see, sir.
Yeah, but anyway, like polymorphic VT, like torsades point is, as Anuradha said, magnesium is the drug of choice.
Okay. వీళ్ళందరూ ఐసీ పరిగెట్టాలనుకుని కంగారు పెడుతున్నా. ఓకే, సో థ్యాంక్ యూ ఎవరీవన్. థ్యాంక్ యూ అన్నదా మేడం, రాణి మేడం, రామ్ ప్రసాద్ సార్, మోహన్ సార్, శేఖర్, and all the seniors for patiently, and my colleagues and juniors for patiently hearing the class, and we had a very nice discussion, and as suggested in the class, we'll go ahead with that schedule of rate control and rhythm control drugs. That idea is nice. Presentation of DNB student followed by Shekhar. So we'll do that either in the current one or the next sitting whenever you're ready. Thank you so much.
PPT పంపించు శ్రీకాంత్.
సార్ అన్ని PPT ఆర్టికల్ కూడా పంపిస్తాను సార్. షూర్.
Thank you
సార్. థ్యాంక్ యూ.
Thank you, Srikanth. Thank you to all.
Thank you, Srikanth.